My name is Markella Zanni. I'm grateful for the opportunity to present on subclinical atherosclerosis and immune activation among U.S. females versus males with HIV. As background to our investigation, an influential epidemiologic study by Dr. Tryant and colleagues querying the U.S. Partners Healthcare Database revealed sex differences in HIV attributable myocardial infarction risk. In this study, the adjusted relative risk of myocardial infarction among females with versus without HIV was approximately 3, whereas the adjusted relative risk of myocardial infarction among males with versus without HIV was approximately 1.4. A second influential epidemiologic study by Dr. Crane and colleagues querying the U.S. CNIX database revealed that there are sex differences in myocardial infarction presentations among people with HIV. By definition, a myocardial infarction is an episode of acute myocardial injury with clinical evidence of myocardial ischemia, that is, myocardial cell death due to oxygen deprivation. Type 1 myocardial infarction is caused by atherothrombosis in a coronary artery supplying the infarcted myocardium. By contrast, type 2 myocardial infarction is caused by myocardial oxygen supply-demand mismatch without atherothrombosis. Dr. Crane and colleagues showed that among U.S. males with HIV who had experienced a myocardial infarction, 59% of cases were type 1 and 41% were type 2. Among U.S. females with HIV who had experienced a myocardial infarction, 46% were type 1 and 54% were type 2. In this context, the key question our investigative team wished to pursue was as follows. Among people with HIV, might sex differences in HIV attributable myocardial infarction risk and in presentations of myocardial infarction be influenced by underlying differences in coronary artery plaque parameters, immune inflammatory biomarkers, or relationships therein? To approach this question, we leveraged baseline data from the mechanistic substudy of REPRIEVE, the randomized trial to prevent vascular events in HIV. REPRIEVE represents an international randomized control trial testing the effect of statin therapy versus placebo to prevent major adverse cardiovascular events among people with HIV with low to moderate traditional cardiovascular disease risk. Participants in the REPRIEVE mechanistic substudy underwent coronary CT angiography and immune phenotyping at baseline and serially. What type of information does coronary CT angiography provide relevant to myocardial infarction risk? First, relevant to both type 1 and type 2 myocardial infarction, coronary CT angiography reveals if subclinical coronary artery plaque is present or absent. Second, most relevant to type 1 myocardial infarction, coronary CT angiography reveals data about whether plaque is characterized by a non-calcified component and/or by select vulnerable features illustrated here. Plaque with a non-calcified component and/or vulnerable features may be more likely to rupture, resulting in type 1 myocardial infarction. Leveraging the REPRIEVE mechanistic substudy, we were thus able, among a primary cardiovascular disease prevention cohort of ART-treated people with HIV living in the U.S., to pursue the following objectives. First, to characterize sex differences in coronary atherosclerotic plaque. Second, to characterize sex differences in soluble immune inflammatory biomarkers. And third, to evaluate whether relationships between immune inflammatory biomarkers and coronary atherosclerotic plaque differ by sex. Let's begin with participant characteristics and plaque outcomes. The primary analysis cohort of 755 participants included 631 males and 124 females, with a mean age of 51 years. As you can see here, median ASCVD risk was higher among males, while obesity rates were higher among females. With respect to plaque outcomes, the prevalence of any coronary artery plaque and of plaque with either visible non-calcified portion or vulnerable plaque features was lower among females versus males. These trends were apparent across atherosclerotic cardiovascular disease risk score strata. The relative risk of any coronary artery plaque and of plaque with either visible non-calcified portion and/or vulnerable plaque features, assessed by log binomial regression, was lower among females versus males. These findings remain significant even after adjustment for both atherosclerotic cardiovascular disease risk score and body mass index. At first, the finding that among people with HIV living in the US, females compared with males had a lower prevalence of coronary artery plaque and of plaque with visible non-calcified portions and or vulnerable plaque features may seem unsurprising. Indeed, similar trends have been observed among studied groups of people without known HIV. But this finding is somewhat paradoxical. If females, both with and without HIV living in the US, are relatively protected from developing subclinical atherosclerotic plaque as compared to males with and without HIV respectively, why is the risk of HIV-associated myocardial infarction among females double that which is described among males? Future studies could usefully interrogate three possibilities. First, that subclinical atherosclerotic plaque has uniquely high prognostic value for ensuing myocardial infarction among females with HIV living in the US. Second, that MI risk among females with HIV living in the US may be mediated through alternative pathways, for example, microvascular dysfunction, which are insufficiently characterized by CT-based evaluation of epicardial coronary arteries. Or third, that females with HIV living in the US experience a disproportionate burden of events which predispose to myocardial oxygen supply-demand mismatch, such as sepsis or overdose of illicit drugs. What about our findings with respect to circulating immune inflammatory biomarkers and immune plaque relationships? Like coronary artery plaque parameters, immune inflammatory biomarkers also differed by sex. Females compared with males had higher levels of IL-6, high-sensitivity CRP and D-dimer, and lower levels of Lp(PLA2 as assessed by linear regression. These differences persisted even after adjustment for ASCVD risk score. Finally, with respect to potential sex differences in immune plaque relationships, higher levels of Lp(PLA2, MCP1, and oxidized LDL were associated with increased prevalence of plaque and plaque with either visible non-calcified portions and or vulnerable plaque features. However, a unique sex-specific immune plaque relationship was also observed. Among females, but not males, D-dimer was associated with increased prevalence of plaque with either visible non-calcified portions and or vulnerable plaque features. These findings intimate two possible mechanisms for sex differences in immune-mediated atherosclerotic cardiovascular disease risk among people with HIV. That is, among females, higher levels of select biomarkers with comparable effect on disease and or equivalent or higher levels of select biomarkers with a greater effect on disease. Noteworthy limitations of our study include the cross-sectional nature of the data and reliance on plaque outcomes as surrogates for atherosclerotic cardiovascular disease risk. However, REPRIEVE will ultimately yield longitudinal data on the development of major adverse cardiovascular events among people with HIV, permitting for more definitive characterization of sex differences in immune-mediated atherosclerotic cardiovascular disease risk and statin-induced risk reduction. This type of work will enable immune modulatory atherosclerotic cardiovascular disease prevention efforts to be optimized for females and for males with HIV. I would like to thank and acknowledge the conference organizers, the REPRIEVE study team, including the co-authors listed, and the REPRIEVE participants, as well as our funders.